As we talk about the pulmonary vascular system and pulmonary blood flow, the very first thing that we need to do is make sure that we understand the pressures involved. So we'll start with pulmonary arterial pressure. There is a systolic and a diastolic pressure here. And so, because of that, we have a mean pressure as well. These ranges can vary depending upon textbooks, so don't get thrown off by small differences. What we want to be able to do is recognize when something is pathological. So, something to keep in mind is that if it's greater than 25, then that could indicate that we have pulmonary hypertension or something that is increasing pulmonary vascular resistance. The mean pressure is calculated the same way that mean arterial pressure was calculated, in that we're taking the systolic pressure, we're adding 2 times the diastolic pressure, and then dividing by 3. And then we have left atrial pressure. This is going to be on the left side of the heart. This is important because this is where pulmonary circulation ends. When we're doing hemodynamics, we're going to see this reflected as the pulmonary capillary wedge pressure. Sometimes it's called pulmonary capillary occlusion pressure. Normal value is about 4 to 12. And again, that's a range that can vary a little bit upon reference. But when we're talking about worrying about when something is pathological, if it's less than about 4 to 5, then we are concerned that there may be hypovolemia or shock, taking into account other values. If it's greater than 18, then we need to worry about it having some type of left-sided heart failure or a valve issue on the left side of the heart, something like mitral valve or aortic stenosis. Now we can talk about pulmonary vascular resistance. Just like in the systemic system, we have opposing forces to blood flow. And so PVR is the opposing forces to blood flow through the pulmonary circulation. When we do that calculation, it will be very similar to systemic. We'll start with our mean pulmonary arterial pressure because that's where we're starting. And then we are going to end in the left atrium or the pulmonary capillary wedge pressure. And then we have to divide that by flow, which is always going to be cardiac output. Pulmonary vascular resistance is affected by both active and passive mechanisms. Let's do some practice with that equation. If we had a patient with a pulmonary arterial pressure of 20/5, a left atrial pressure or wedge pressure of 6, and a cardiac output of 6. So the first thing that we need to do is find that mean pulmonary artery pressure. If you need help, that's the equation. We're taking 2 times the diastolic pressure, adding systolic pressure, and then dividing that by 3. What do you get as an answer? It's going to be 10. After that, we can find SVR. So remember, we're taking the starting point minus where the ending point and dividing by flow. Here's the equation, 10 minus 6 divided by 6, and that's going to give us 0.67. Now, PVR is typically measured in dynes, and so to get that answer, we're going to multiply it by 80. So take that 0.67 times 80, and that actually gives us 53. Normal PVR is 45 to 120 dynes per second per centimeter to the fifth. What can cause changes in PVR? Remember, we have both active and passive mechanisms. So we'll start with active, and that includes hypoxemia. The vessels will vasoconstrict to shunt blood to better ventilated parts of the lungs. Same with acute hypercapnia, because we get increased hydrogen ions, that's also going to cause restriction. So let's say I have 2 alveoli here, like in different parts of the lungs. We'll do another alveoli over here. And we have blood vessels, of course, going to both of them. And so what happens is that this blood vessel is full of fluid. So we have no oxygenation happening here. So the blood vessels themselves are going to start to vasoconstrict because it says, hey, there's nothing here for me to pick up, and there's more over here. So that will allow there to be more blood flow going through this section of the lung, but basically help compensate for that decreased oxygenation. Medications can also change PVR. So, for vasoconstriction, anything that stimulates the sympathetic nervous system can cause vasoconstriction in the pulmonary system as well. For vasodilation, very specifically to vasodilate the pulmonary vessels, I could give oxygen, particularly when I'm trying to reverse hypoxemia. If the patient's hypoxemic and they have constricted blood vessels, if I give oxygen, that should be helpful. I may also have to give other drugs like prostacyclins. Epiprostenol is an example of one, or nitric oxide that can also help vasodilate. Aminophylline and calcium channel blockers will also vasodilate. Calcium channel blockers are actually one of the first line drugs when a patient has primary pulmonary hypertension. And of course, pathological changes, right? Because anything that results in a low alveolar O2 or hypercapnia going to cause that vasoconstriction. If I have a vessel blockage like a pulmonary embolism, that's going to increase PVR because it's going to prevent blood flow from going through. And then I also have diseases that cause vessel destruction. Both emphysema and pulmonary fibrosis will actually cause destruction of the alveolar capillary bed. And then the last thing is vessel compression. So if we have a pneumothorax or hemothorax or some type of mass that's pressing on those blood vessels, that will increase PVR. We can also get changes in PVR from passive mechanisms. Vessels in the lungs can be recruited and distended, and left atrial pressure is also going to affect PVR. If we have high atrial pressure, we have blood that's going to be backing up into the pulmonary system. And as that happens, we will get an increase in pulmonary artery pressure as well. And then just with lung volume changes, even from a normal breathing physiological standpoint, we do get changes in PVR from inspiration to expiration. In the alveolar vessels, the capillaries, pleural pressure causes the PVR to be higher on inspiration than expiration. That's important to note because when we use mechanical ventilation, PVR will increase even more because there is additional intrathoracic pressure. And then you also have extra alveolar vessels. Those are going to be the arterioles and the veins on either side of that pulmonary capillary system. During inspiration, those extra alveolar vessels distend, and then you also have corner vessels. These are at the center of multiple alveoli. They're going to have a PVR that is lower on inspiration. And so it's just really important to note that PVR can change in response to both high and low lung volumes because we get normal changes with it just from inspiration to expiration. So keep in mind that if we have mechanical ventilation, we are getting higher PVR because we have more intrathoracic pressure. But also, if we give too much volume, that's also going to increase PVR. And on the flip side, atelectasis can also increase PVR. So we don't want too much volume in the lungs and we don't want too little in the lungs. So let's go ahead and do a few case studies. We'll start with this first case, a patient that has pulmonary fibrosis. They have a SAT of 84, a mean pulmonary artery pressure of 40, left atrial pressure of 12, and a cardiac output of 5. So the first thing that we need to identify is what is PVR. So let's do that calculation. We start in the mean with the mean pulmonary artery pressure, so 40. We end in the left atrium, so that's going to be 12. And then we're going to divide by our flow, which is the cardiac output of 5. So we do 40 minus 12, that is going to give us 28. And then we're going to divide that by 5, which will give us 5.6. Now to get dynes, we're going to multiply that by 80, and that will give us 448 dynes per second per centimeter to the fifth, running out of room there. So what do you think of that value? It is high, and is that because of an active or a passive mechanism? This is definitely an active mechanism here. Why do I say that? Because I have hypoxemia, that 84%, is going to cause vasoconstriction, an attempt to shunt blood to healthier areas of the lungs. But with pulmonary fibrosis, I also have vessel destruction. So both of those things are going to lead to an increase in PVR. What can we do for this patient? The very first thing that we need to do is to give oxygen. It's very important that we keep saturation greater than 90% in these patients as much as possible. We could also do a pulmonary vasodilator. For pulmonary fibrosis specifically, we typically use treprostinil. Case number 2. This patient has CHF and has these values. What is the PVR? Let's do our calculation. We are starting in the pulmonary system, so 35 minus the left atrial pressure of 20. That's going to give us 15. Then we're going to divide that by our cardiac output of 3. And so that will give us 5. Then we can multiply that by 80 to get dynes, and that will equal 400. So that 400 dynes, that's still pretty high, right? So why is it high? Is this an active or a passive mechanism? It's going to be more passive because it's going to be due to that high left atrial pressure. That high left atrial pressure is causing blood to back into the lungs. So what's the best way to treat this patient? Really, we need to treat the heart failure. And so that's going to involve giving diuretics, potentially an inotropic medication to get the heart pumping more effectively. But instead of 90%, it's certainly oxygen is also going to be appropriate in this case. Okay, and then we're going to take a look at case number 3. This patient is on mechanical ventilation. What is the PVR? Again, doing our calculation, starting at the pulmonary artery, subtracting out the left atrial pressure of 10, that will give me 20. And then I'm going to divide that by 5, and that will give me 4. And then if I'm going to get dynes, I'll multiply that by 80, and we'll get 320 dynes per second per centimeter to the 5th. Why is it high? Is this an active or a passive mechanism? It really could be both, right? We could have more passive, potentially some active, though. We have high volumes, and those high volumes are going to increase PVR. We might get some overdistension, which will cause some active compression. That increased intrathoracic pressure is going to increase PVR, especially on inspiration. What's the best way to treat this patient? We need to ensure that the tidal volume is 6 to 8 mLs per kilogram. Right now, that 12 mLs per kilogram is definitely too high for them. Let's look at our key points. Mean pulmonary arterial pressure is about 10 to 20 millimeters of mercury. We should be concerned if it's greater than 25. PVR increases as pulmonary arterial pressure increases. So you can generally tie these two values together. Our calculation, make sure that you remember that calculation as you are going through hemodynamics. Normal PVR is 45 to 120 dynes per second per centimeter to the 5th. Note that vascular pressure is really much lower in the pulmonary vascular system compared to systemic. It is affected by both active and passive mechanisms. Intra and extra pulmonary vessels have passive vascular changes that occur with normal breathing and at high and low lung volumes. Active mechanisms include pathological changes that cause hypoxemia and or hypercapnia, medications or vessel destruction, blockage, or compression. Increased left atrial pressure creates back pressure that increases pulmonary artery pressure and PVR. And mechanical ventilation with high volumes and or high PEEP can increase PAP and PVR.